Family. Good evening, National Pharmaceutical Association family, or as we like to call each other, NAFAM. My name is Dr. Frank North, and I am your National President of the National Pharmaceutical Association. And I want to thank you for joining us this evening in this conversation about monkeypox. Before I introduce the facilitator for this evening, I'd like to share 4 things with you about the National Pharmaceutical Association. One, I'd like you to know that we have launched our Life Membership campaign. Life membership for the National Pharmaceutical Association is $2,500. During this campaign, life membership is $2,000, and that $2,000 is able to be paid in 2 installments of completing in 1 year, $1,000 each year. Next, I'd like for you to get more information about our partnership with Medicus CME, where we are delivering education around opioid abuse and misuse, and we're seeking members to become leaders in this effort, and each leader has the opportunity to earn $1,500 upon completion of the ask. So if you want more information about that, please email npha@npha.net. Next, I'd like you to look out and save the date for September 10th. There'll be some exciting opportunities for you to engage with the NAFA board in an open forum. Lastly, I invite you to contribute to our National Pharmaceutical Association's Foundation's 75 for 75 campaign. This is where if 84 pharmacists contribute $75 once a month for 1 year, we can achieve $75,000 to help NPhA Foundation support NPhA and bringing you more interactions and activities such as this tonight. So I thank you for entertaining me and learning a little bit more about the National Pharmaceutical Association and the events that we have going on. I will now turn over the forum to Dr. Jacqueise Unonu, who is our National Clinical Initiatives Chair, to introduce our panelists and get us underway with learning more about ways we can impact monkeypox. Dr. Unonu.
Good evening, everyone, and welcome. Again, as Dr. North has said, I will be your moderator for this evening. Today we have special panelists for you that will bring you some in-depth and up-to-date information regarding monkeypox, which is all the buzz at the present moment. Our speaker is the highly capable Dr. John T. Brooks. Dr. John T. Brooks serves as the Chief Medical Officer to the CDC's Division of HIV/AIDS Prevention, where he coordinates the division's activities related to the new National Ending the HIV Epidemic initiative. His primary area of expertise is prevention and treatment of HIV infection. He is presently also serving as the Chief Medical Officer, the CDC's Multinational Monkeypox Outbreak Response. Dr. Brooks has led teams during the CDC's emergency responses to anthrax, SARS, Ebola, Zika, HIV, and hepatitis C outbreaks among people who inject drugs, and was Chief Medical Officer for the COVID-19 emergency response. Dr. Brooks came to the CDC as an EIS officer and in 1998 after completing medical school, residency in internal medicine, and a fellowship in infectious diseases through Harvard Medical School. He will be presenting, as I said, important information regarding monkeypox for about 20 minutes, after which I will open the floor for questions and discussion. So please hold all your questions until that time. You will unmute yourself and ask your question one person at a time. If you would prefer to place your question in the chat instead of speaking, that option is available to you as well. We also have some important links that have been placed in the chat for you by Dr. Riley. So feel free to use that as an additional information after the session as well. I will now turn it over to Dr. Brooks.
Well, thank you very much, Dr. Unonu and Dr. North. I'm going to go ahead and share my screen. I need to have the ability to do that. It looks like it might be disabled right now, but I appreciate the very generous introduction. And what I'd like to do over the next 20 to 30 minutes, probably 20, if we can try, because I want to make sure we have plenty of time for any questions that you have. go over some of the background some background information about monkeypox and what we know with regard to its clinical presentation and management. So let me share my screen. I'm still getting it. The host is able to participant screen sharing still. I don't know if Dr. North, you or Dr. Unonu were able to
Let me see if I can do it.
get in there, and otherwise I'm gonna
Go ahead.
All
Try it now.
right, beautiful. There we go. You have to see it loud and clear now.
Okay.
Great. So this is monkeypox for you guys, and let's get started. So what is monkeypox? Well, the monkeypox disease is caused by a virus with the same name, and this until last May was considered a pretty rare disease caused by an infection with the appropriately named monkeypox virus. And this virus belongs to the genus of orthopox viruses, ortho referring to the fact that they look square and boxy sometimes under a microscope. And there's some very famous members of this genus. The virus that causes smallpox, called variola, is the most famous one. But there's also a different flavor called vaccinia, and this is the virus that's in the smallpox vaccine that gives you immunity to smallpox if you get vaccinated with it. And then there's a whole host of other orthopox viruses that infect other mammals, including cowpox virus that's pretty famous. Now, what's interesting is that this disease actually is not a disease that is common among humans or non-human primates. It was just coincidentally discovered in the late 1950s when it was affecting 2 colonies of monkeys being kept for research in Denmark, and the name was attributed at that time to it being monkeypox, but the actual reservoir remains unknown, although we believe it's likely to be small rodents in Western and Central Africa, probably either squirrel-like or rat-like rodents. So let me talk a little bit about what we know about trends in the disease right now. These are data from Our World in Data. This is a really nice website, linked down at the bottom left if you'd like to use them later, which may be well known to you for tracking SARS-CoV-2 or COVID data for the last 2.5, 3 years. But they've also picked up following monkeypox. And here we see from around the world what the total daily number of reported cases has been. And you can see there's been a very steady increase since the middle of May up through moving into this later, close to the end of the summer. And what's really interesting is although we're still bouncing around at 800 to 1,000 cases per day, there's some early evidence that at least worldwide, things may be beginning to plateau. And I'm hopeful that this trend will continue. When you look at where the disease is occurring worldwide, however, you can see it's kind of disproportionately distributed in a couple of important ways. So far, we've had close to 47,000 cases as of today reported worldwide, and these are predominantly in the United States. The figure here shows the world, and within each country there's a circle. The color orange means it's the country where the disease has been introduced, where it's not endemic, and the blue circles are where it is endemic. So those blue circles are mostly in Western and Central Africa, where the disease has been recognized for over half a century. And the size of the dot refers to the number of total cases there. And you can see the US is quite large compared to these other countries. We represent now a little over 1/3 of all the cases worldwide. What do we know about the demographics or the characteristics of the people who are being diagnosed with this disease? And this is an important point to make. First, the bottom line here is that this is a disease presently very disproportionately affecting gay, bisexual, same gender loving, and other men who have sex with men, as well as trans men and trans women. The median age is 38, so in the 3rd decade, but can range quite high. We have patients up into their 6th and 7th decade of age. Almost exclusively male, 99 in these data taken from a study in New England Journal, cited again at the bottom left, but which is very typical of what we're seeing in all the different places people are looking. Most of the people are male, over 99%. And in terms of their sexual orientation, the vast majority, in this case 96%, are gay, bisexual, same gender loving, or men who have sex with men. And then we know these people are sexually active. We know it in 2 ways. First, look at the high fraction of people with HIV here. 41% of persons diagnosed with this disease worldwide thus far have had or living with and have HIV. And that's really high compared to what we would expect even among MSM. That's a high fraction. What does this represent? Well, the good news here is that at least thus far, the people who are affected by HIV, when we've been able to look closely at the quality of their clinical condition, is they're doing well. These are mostly people who have access to effective therapy, their viral load is suppressed with antiretrovirals, and their CD4 cell counts are robust. So I think that's telling us this isn't the predominance of HIV here is not because the HIV infection itself is somehow predisposing people to getting monkeypox, but rather, as we see with other diseases that affect the same population, it likely represents underlying ongoing risk behavior for exposure and acquisition through sexual activity. I'll just note that if you look at STDs in the United States, and specifically gonorrhea and syphilis, that among MSM diagnosed with these two sexually transmitted infections, the fraction who have HIV is often in this same range, somewhere between 30 and 50%. Also, though, you can see that when you ask them about their sexual partners, the median number of partners in the last 3 months has been 5. And when you look at the, if they've got another sexually transmitted disease at the time they're diagnosed with monkeypox, almost a third had another STD, gonorrhea, chlamydia, syphilis, herpes, something else, at the time of monkeypox diagnosis. Again, evidence these are sexually active persons. There also have been people diagnosed not just with the STDs that I've mentioned, but acute HIV. So their initial diagnosis of HIV was at the time of monkeypox diagnosis. Here in the United States, we have data also on race ethnicity. We're a very heterogeneous population. And it's important to pay attention to these sorts of variables here. And what I want you to appreciate are a couple of things. First, in the dark blue are persons who are self-identified by race ethnicity as white or Caucasian, and you can see that their fraction among all persons who have monkeypox was elevated initially and then has declined. And this, we believe, probably represents a typical phenomenon, which is those at the front of the line are the first to get care. And so the people who have access and the ability to get into care and are the ones who are first being diagnosed. But over time, we've seen that this is that fractions of other populations have increased, particularly first among Hispanics and Latinos in those kind of green bars, but that's remained pretty steady at 25 to 30%. That still, however, is very out of proportion to the representation of Hispanics and Latinos in the general population, which is probably closer to 18%. And even more striking is Black and African American overrepresentation in these data. Not initially a large fraction, but now, again, also about 1/3 for a group that in the US general population represents about 12% of everyone. So this is something we got to keep our eye on. And for those of you who follow HIV, which is where I spend a lot of my career, we see the same disproportionality in HIV and STDs. So again, very consistent picture here of monkeypox entering a high-risk population and affecting it disproportionately. What's going on in this country? Well, today we have just under 17,000 new cases reported to CDC. And they are predominantly in the states shown on the right, and these states represent over 70% of all the diagnoses that are represented here. The couple of things to say. First, these are also among the most populous states and the states most affected by HIV. So we're not particularly surprised that this is where monkeypox is being diagnosed. And it's been diagnosed in every single state and most territories, including Puerto Rico. A couple of things that I want to bring to your attention is these aren't necessarily statewide epidemics or outbreaks. Within each of these states, it's really in the major urban center that we're seeing the greatest number of new cases. So New York City, Chicago, Atlanta, Miami, Houston, Dallas, San Francisco, and Los Angeles are places where it's particularly concentrated within a state. But we have other examples, such as the upper West, Montana, Wyoming, and the Dakotas, where we have a handful of cases, but they tend to be mostly rural. This slide looks at what we call an epidemic curve showing the daily number of cases over time. And it kind of looks a little bit like a comb or a toothbrush, we say, because on the weekends, reporting goes down. But if you kind of let your eye drift over this and draw a line, you can see it's been a steady increase since the reporting began to be followed. But then more recently, maybe is it beginning to top off and go down? I'm going to be very cautious here and remind you that it takes time for a case that's been diagnosed to end up in our data bank so we can count it. There's a whole chain of things that has to happen to get it from the diagnosis into the place where we can count it. And that lag in time is often not accounted for in the last couple of weeks here. So we're always very careful about over-interpreting the most recent data, but we're hopeful. We're very hopeful. Testing in this country, just some good news here that initially, and this is a figure that shows the number of testing capacity in the orange line and the number of tests actually performed in dark blue. This is a story that's really nice that basically says we've got a lot of testing capacity and you shouldn't hesitate to collect a specimen and send it in or assist someone in doing so if you suspect they've got monkeypox. In orange, early in the epidemic in May, we were sort of limited in our capacity because we were using mostly public health laboratories. But then in the early summer, we were able to engage 5 large national laboratory companies who have increased our capacity from 6,000 specimens a week to almost 80,000 specimens a week. And you can appreciate from this figure where the blue shows the number of tests being performed, we've got plenty of room to grow. No, we're currently using about 15% of our capacity. So please don't hesitate to diagnose or to rather to collect a specimen for diagnosis based solely on concern that there won't be testing available. Let's talk a little bit about the illness itself. I think this is kind of interesting. And this is first I'm going to describe what the classic presentation of monkeypox as described mostly in West Africa and Central Africa, particularly in Nigeria, Democratic Republic of Congo. A couple of things here first. Incubation period is about 1 to 2 weeks. So after exposure, it takes about 1 to 2 weeks for a person to become ill. That range can go all the way up to almost 3 weeks. Now, this disease is classically always has what's called a prodrome, which some of you may be very familiar with this term, the idea that there's a set of constitutional or systemic symptoms and signs that occur before the rash occurs. And these are typical of a flu-like illness, fever, malaise, headache, and weakness. But one thing that's different is this lymphadenopathy or swollen lymph nodes. And that's very characteristic of people just before they get the rash, particularly in the neck and in the armpit. When the rash appears, and it can happen very quickly after the prodrome, a person can just be starting to feel sick with a fever, and then the rash occurs a couple of hours later, or it can take a couple of days. But when the rash appears, it tends to occur simultaneously over most of the body. So all of the lesions you're going to get generally pop up at once. And they go through this very standard phasic development of 4 stages, with it first being sort of flat and red or macular. Then it gets to be a bump or a papule. That bump fills up with clear fluid and becomes a vesicle, or becomes a vesicular, and then that fluid starts to get pussy, and you get a pustular lesion. So it goes from flat and red up to this pussy thing before it scabs over and falls off. And these are well circumscribed, deep-seated, so if you touch one, you can really feel like it's rooted in the skin, and importantly, these are painful. Also, they develop an umbilication. And what is an umbilication? That's basically a divot in the middle of the lesion. So instead of being flat and round, or as it moves into that vesicular and pustular stage, it'll get a little belly button in the middle, or an umbilicus, and that's also very characteristic of this disease. When it's disseminated over a person's entire body, it tends to predominantly involve arms, hands, feet, and legs. And it can occur on the palms and soles, which is like syphilis, for those of you who know it. So it can look like other diseases, and we'll come back to that in a moment. An illness duration is typically 2 to 3 weeks. These are some photographs on the left from North America, on the right from West Africa, where we had patients on the left from a outbreak in this country related to prairie dogs in 2003, and then lesions in more endemic countries. And they're pretty much the same look here. The point I wanted to make with this photograph is first, just so you can see what it's like in different skin tones, what some look like with umbilication, and to make the point that notice almost all of these are in the late stage, vesicular or pustular. And the point I'm making is that many people don't recognize that it might be monkeypox early on when it's just that flat red rash, or it's starting to get bumpy, maybe like herpes. But by the time it gets to this, you should be thinking monkeypox. All right, how does this differ, what I just described, from what we know today and what we're seeing in this sort of new version of monkeypox? Well, the first is that the pattern is different. The lesions tend to be scattered in different parts of the body, and they don't necessarily all have to come on simultaneously. That you may get waves of lesions that pop up in one place, another group pops up somewhere else. One group may get a bunch of satellite lesions. It often starts in mucosal areas, which is extraordinarily different than what we've seen previously. So that would be in the very tender genital, perianal, oral mucosa. And as I mentioned, may not develop simultaneously. And when it's in these areas, in your genitals, around your butt, in your mouth, it is painful and can cause problems. A man's penis, the head of the penis can get so swollen, they get what's called balanitis, urethritis, where your urethra is so inflamed, it's difficult to pee. Men can experience spasms so profound they need to be catheterized in order to urinate. And then they can sometimes, when the lesions heal, they tend to cause scars. This is a scarring disease, and you can have a restriction of the foreskin over the penis called phimosis, requiring, unfortunately, in some cases, we understand that men have had to undergo circumcision. The really most prominent thing we're hearing the most about, though, in terms of mucosal involvement, is proctitis, or an inflammation of the anorectal canal. This is anorectal pain described as lancinating, like glass shards, slicing like a knife. Can have some other issues like tenesmus and rectal bleeding associated with it. And it doesn't have to be always associated with visible external lesions. Now, they can be there. We've certainly seen, and I'll show you some examples. So trigger warning, there are going to be some pictures in a minute of some of these lesions on somebody's private. But sort of what you can have perianal, vesicular, pustular lesions as well as ulcerative skin lesions around there. But you don't have to. We've got plenty of examples now of men whose only symptom was anorectal pain, and when they were able to be examined with an anoscope, you could usually see lesions inside their anorectal canal. And then lastly, oropharyngitis, so inflammation in the mouth and the throat can lead to swelling, abscesses, and difficulty swallowing or pain, dysphagia, severe enough that they have to get a nasopharyngeal tube in place to keep them hydrated with water and fluids and to push food down into their stomach. And what's also really interesting here about this presentation is the prodrome, and the fact that it's often absent. These people are now getting the rash first, and then maybe the prodrome comes along, but plenty of people have had the rash and no prodrome, or no symptoms afterwards. It's not a prodrome if it comes afterwards. Some still are getting symptoms before they get lesions, but the absence of the prodrome is particularly interesting in this new presentation. So pictures, these are photographs you can look at from the Thornhill article over on the left of different body parts where the lesions are involved. The one thing I want you to really appreciate in the pictures on the bottom right, the oral and perioral lesions, imagine that these are scarring. I mean, these men will be left with scars probably where these are located, and that can be cosmetically very sensitive, not to mention in the upper pictures, the discomfort that it's causing around the penis and the anus. And I don't know how many of you all have had the opportunity to see and treat STDs, but this is what some other STDs can sometimes look like. But what we're hearing is the pain is orders of magnitude greater. So this is a disease where when people present with it and you suspect it, don't be surprised if they're saying it hurts a lot more than you might think it would hurt based on what you're seeing. Now, in the table on the left, I just want to point out something also different compared to the prior distribution of lesions I talked about before. Remember I said they were centrifugal, which meant on your hands and feet, on the extremities. Now we're seeing a real concentration in the trunk, and particularly in the pelvis. So 73% of persons are reporting skin lesions, 73%, 3/4 in the anogenital area. And the prevalence of lesions of the mucosa in those areas is really high, 41%. Most, not surprisingly, anogenital, but we're also seeing oropharyngeal. So bottom line, how does this presentation today differ from what we've grown to expect based on prior experience? And that is less prodrome and a lot more anogenital lesions. All right, how does it spread? Spread person to person through direct contact, either with infectious rash on a person, but the scabs are also infectious, and so are certain body fluids like saliva can contain live virus. And that's why we believe people can be exposed and infected through exposure to respiratory secretions. I'm speaking right now, I'm sure there's little tiny, gross, I know, little tiny spit particles coming out, but if you were up close to me, you might be exposed to those. Now, we're all we've all been trained to be very careful about COVID. And COVID can, drift across the room. And if the circumstances are right, you could be pretty far away from somebody, but enough virus could build up in the air that you could become infected. That's just not the case with this virus. The available evidence, and we've been following this virus, as I mentioned, for decades now, is that if you're going to be infected in this way, it's close contact, face-to-face, talking, kissing, intimate contact, cuddling, not speaking to people across the room. You can also be infected in two other ways. The first is transmission through clothing or linen, or touching an item that's heavily contaminated with virus. So that kind of an item is called a fomite, and that is something that's contaminated with a pathogen like a virus. And you really have to get something that's pretty well soiled. This isn't something that you have to worry about when you go to Target or Lane Bryant or Neiman's, wherever you go shopping, that if you try on clothes, you might be putting something on that somebody just had and you're going to get monkeypox. This would have to be visibly soiled based on experience. We also know that the routine things we do to clean clothing and linen, a regular wash cycle with washing powder as well as drying, kills this virus, which is very sensitive. And in fact, one good piece of news is ultraviolet light is very sterilizing. So if you put your stuff out to dry in the fresh sunshine, there's an added plus there. Also, in the case of a pregnant person, virus can't be transmitted if that person is infected through the placenta to the fetus. And how long are you infectious? You're infectious from the moment the very first symptom begins until the very last scab forms, falls off, and fresh skin is evident under the scab. Again, remember that can be around 2 to 3 weeks. We're very concerned about monkeypox in people with HIV. I know I'm speaking to an audience of pharmacists, so I hope you'll find this useful. We think a lot of such a high prevalence of HIV. We wanted to make sure that everything was that we understood there were any important interactions here between HIV and monkeypox. And a couple of things to point out. The first is that I mentioned, as you heard, that I hope you heard that people presently affected in the current outbreak are generally doing well. So people with HIV who are getting monkeypox in places like the United States and Europe and Australia and more developed countries are generally doing well because they're well treated, and their outcomes are not that different than people without HIV, to the best of our knowledge. But what we do know from small studies, but important ones, particularly in West Africa, from Nigeria, that people who have advanced HIV or who are not virologically suppressed, CD4 under 350, or not virologically suppressed, they're really at increased risk for life-threatening disease and pretty disseminated disease and prolonged shedding of virus. So it's important not only to reiterate patients who have HIV to take your medicine and stay suppressed, but to recognize that for a person with advanced disease, they should be watched very closely. There is something we can help people who've been exposed, not persons who are ill, but people who've been exposed, to avert infection in the form of post-exposure prophylaxis. We recommend now for the population at greatest risk that MSM with known or even presumed exposure to monkeypox, that they can be vaccinated with what's called Jynneos. This is a vaccine that is a live virus. I'll talk about it in just a moment, but I'll explain why it's considered safe for people with HIV. In fact, remarkably, this vaccine was specifically studied in people with HIV because we wanted an alternative to the other vaccine, a safe alternative to the other vaccine. Antiretroviral treatment is available for monkeypox. The main drug is a drug called tecovirimat or TPOXX. Widely available, can be accessed through an investigational new drug protocol. And the reason it's in part of an investigational new drug protocol is that we just don't know if it works yet. You're going to want to learn, I think, about something called the animal rule, the way that FDA, Center for Drug Evaluation and Research, approves the drug for human use, but based only on animal data. And that's what happened here with TPOXX. We didn't have, thankfully, people with smallpox, for which the drug was originally developed, to see how well TPOXX with tecovirimat, that's the formal name, works. Nonetheless, we think it's safe, and we want to provide it compassionately to people who are suffering. So it's being made available through this protocol. And if you all have questions about that, I'm happy to talk about that at the end. The good news is there is no known drug-drug interaction that are meaningful enough that we have to be very concerned between antiretroviral medicine and this drug, tecovirimat, for people already taking ART. The one thing to think about is if you have somebody who is thinking about starting injectable cabotegravir rilpivirine, if they're thinking about the long-acting cab rilpivirine drug, which is a fantastic thing, know that because of the interaction of tecovirimat with one of its components, with the rilpivirine, we recommend that you delay starting this drug unless you absolutely can't avoid it. But better to delay for at least 2 weeks after completing tecovirimat, so that's out of your system and it won't interfere with the ramp up of getting a good serum level of cab and rilpivirine. Let's talk about the vaccine briefly. This is what it looks like in a little vial. It's safe for people with HIV because I mentioned it's live, but it is not replicating. It is attenuated. It's been passaged in a way that it doesn't replicate. It doesn't reproduce itself in our tissues, and so it's considered very safe compared to well, first, and for that reason, it was licensed both for prevention of smallpox and for monkeypox. And I left the D out of and go and fix that later. In the third bullet, though, I want to point out that the other reason we like it is because the alternative vaccine, which, by the way, there's boatloads of it in this country, called ACAM 2000, has two disadvantages. The first is that it has a predictable number of side effects, not all of which are benign, including myocarditis in maybe 1 to 750 to 1 to 1,000 people. And that can be unpleasant to have to manage. And also, more side effects really undercuts our efforts in vaccine competence. We want people to feel they're getting something that is going to be as safe and less harmful for them as possible. Also, ACAM 2000 is a replicating virus, and this virus, the vaccinia virus, can cause disseminated vacciniosis or progressive vaccinia in a person who's immunocompromised. So imagine, do we really want to use this vaccine in a population where a good fraction may have HIV? Topic for discussion later, perhaps. It is distributed to jurisdictions through the Strategic National Stockpile, and we are doing our darndest to make it available to people as rapidly as we can. One of the ways we're doing that is through the strategy of intradermal dosing, something you may not be unfamiliar with because we just haven't done it for generations here in the United States. I'll just remind you that the original first vaccine that was developed by Edward Jenner, was for smallpox. And how was it administered? It was administered through a practice called variolation, where you scratch the person's skin and you rub the vaccine onto the skin. So the idea is you're inserting it into the skin. And this was the first way that vaccines were administered, and it's not such a bad way to go because your skin is a fantastic immune organ and does a beautiful job detecting antigens and turning your immune system on to fight. This vaccine that we're using now, modified, is based on something called the Jynneos vaccine, is based on a form of vaccinia called modified vaccinia Ankara, MVA, and it was actually administered as part of Germany's strategic effort to eliminate smallpox in the 1970s, thousands of people. So it was demonstrated safe and relatively easy to do. And it's also been given as a boost with other vaccines. Now, one of the biggest side effects is redness at the inoculation site, and in particular, itching. Your immune system in your skin is so good that when it sees something, it's pretty reactogenic, and you can really get a lot of itching at the site. But we have ways of helping people manage that. What I really want to say here, though, is something really important, that the dose that we're giving intradermally is the right dose for the right tissue. It is not lesser, it is the right dose. And we know this because of a clinical trial that was done where we found that if you gave 1/5 the dose that comes in each of those vials I showed you, intradermally under the skin, according to the same schedule that it was given as currently licensed into the arm subcutaneously, it was equally immunogenic. Okay, so you got the same bang for your buck no matter which way you gave it, and it's using less vaccine, although it is, as I mentioned, causes more redness and itching and some local pain. But the advantage there is that means we can make so much more vaccine available to people and get so many more people who need it vaccinated as quickly as possible. Just I want to talk quickly that at CDC, we're big proponents of harm reduction in my day job in our Center for HIV, STDs, tuberculosis, viral hepatitis, and adolescent health. And we're bringing that same approach to how we address monkeypox in the United States. We are really focused on reducing stigma, meeting people where they're at, and working to prevent discrimination against the LGBTQIA+ community. The way you do that is first, you give people the information they need to make informed choices. And you do it so that you can empower them with the best harm reduction practices. This an example of a PDF we've made that's available as a website also, and there'll be in some links at the end, shows you an example of what we've been developing. And our main purpose is to communicate without shame or judgment, just recognize the person's lived experience and help those disproportionately affected by the virus do what they can for themselves to protect themselves and others. So you might ask, making recommendations for people to change their sex behavior is fraught with difficulty. I've often joked with people that if it was so easy to tell people to stop doing things that were bad for themselves or that were not bad for themselves, that was great, but that might inadvertently harm you, that we wouldn't have problems. I'd be out of a job. But this is really interesting data. We used a survey that was administered by Emory University, the Adult Men Information Survey, I believe is what it stands for, AMIS, where we routinely query a panel of randomly selected and relatively representative men who have sex with men about what's going on in their lives, what are they doing? And look at these data across the board, about 50% of these men said that because of monkeypox, they've either reduced the number of sex partners, reduced one-time sexual encounters, or reduced having sex with partners met on dating apps or at sex parties. And I'll just tell you, in the world of HIV and STDs where I work, that kind of change in self-reported intention, and we call it intention because we're not really measuring their behavior, but just the intention to change is huge. Now, we know that people don't always practice what they preach, and sometimes you make an intention that's high, but in reality, after a couple of drinks, the numbers may not be quite so high. But this is pretty remarkable, and I think speaks to, I hope, not only the potency of this unfortunate epidemic on making people think a little bit for the short term, not forever, but for now, about changing behavior. And maybe actually some of our tools are getting through. I'd like to hope that's the case. It's hard to measure improvement. I just want to mention, I won't go through these in detail, just to highlight here a whole bunch of community resources, websites, fact sheets. We really encourage you to please go look at these and see if you can use them in your daily practice, or people you support could use them. Particularly the one on reducing stigma in communication and community engagement. And the fourth one, our health equity guiding principles for inclusive communication, are really helpful. Also, we have things directly for patients if you're sick, things to know about monkeypox, 5 things sexually active people need to know about monkeypox, and then the clinical considerations for people with HIV that I mentioned before. And then lastly, we have a whole bunch of coming attractions with testing and vaccines, a risk graphic and toolkit that we hope will be helpful for people. So I'm going to stop there, but I think I may have exceeded my time just a little bit, and I would love to answer some of your questions. And the ones I can't answer, I'm hopeful that my good colleagues on the line will help us. And I see there are a lot of questions in the chat, so let me stop sharing. Here I am again, and thank you very much. Over to you all for Q&A.
Yes, sorry, I was looking for my mute button.
Don't worry.
Thank you so much, Dr. Brooks, for that information. We do have a lot of questions from our audience members, so I will jump right in. Again, you may unmute yourself if you would like to ask additional questions. In the meantime, I will start in the chat and then we can go from there. Okay. One of the questions, excuse me, what do you think is the reason for the lag in testing, as we saw in the graph depicting testing, that there is a large volume that's available for testing, but the numbers in the blue graph that we saw is kind of lagging behind?
I hope that it's because there's not so much disease out there that people feel the need to be testing a whole lot. It's reassuring that we have plenty of capacity now. I think early on, though, there was probably a lag in testing, not only because there was low capacity, but also people didn't know how to go about getting the test. With a new disease, particularly during an outbreak, and if you're not using commercial laboratories, it's hard to find out where to get the test done. And those of us, when you practice medicine, and nowadays, if I want to do a glucose test, I just go on and order it off the electronic order entry system. And that system wasn't in place. You had to call the health department and arrange for a specimen. We've been reducing those barriers, and now you can directly order it from LabCorp, Quest, and a bunch of other companies, and they have it on their order entry set. And again, the point I want to make is if you have a case where you're suspicious, encourage either you or the people you're working with to sample and test. This disease clinically can look like other diseases. If you're not thinking monkeypox, it could look like herpes, it could look like varicella or chickenpox down there, or zoster. Syphilis, which has a big lesion, could look like monkeypox. So just keeping an open mind around the differential is critical in this case.
Thank you for that response. And also you can raise your hand if that will help, if there are multiple people trying to talk at the same time, and that way we'll keep some order for the question and answer section. Okay. What is your experience with payer barriers to access? And is treatment and screening managed? Will it require PA, things like that?
Yeah, so let's talk about that for a minute. There's a little bit of inequity in the access here insofar as testing, if it's done at the state health laboratory or through the public sector, is without cost. But presently, the cost of testing in the private sector through these laboratories I mentioned is a billable service. Now, different healthcare systems can find ways to carry the burden so others don't have to, but that can be a challenge. The drug I mentioned, tecovirimat, that is available to all Americans and anybody who needs it in this country through the U.S. government and the national stockpile at no cost. But there can be administration costs with, as you all know, as pharmacists, there are the administration costs that come with things of doing the labs you might need, if there are any that are necessary, administering the drug, the cost of the visit. Again, if a person is in a healthcare circumstance where they are covered through public health insurance, then it's taken care of. But for people who are outside of federally qualified health centers, the William White HIV/AIDS care program, or other public access services, it may be a bit of a challenge. Our experience thus far, though, has been that most people, I'm not aware of people who needed care that didn't get it. I'm sure we'll hear about it, but I haven't heard about it yet.
Right, still in kind of some early stages. And then also, I know a lot of the pharmacists on the line are interested in pharmacists being able to administer the vaccine. So what is in the works, do you think, with regards to an EUA that supports pharmacists vaccinating or administering the vaccine?
Great question. So an emergency use authorization, or EUA, would have to be coming from FDA and not from us. But that doesn't mean that we can't distribute. We help distribute the vaccine. It doesn't mean it can't be distributed to pharmacies. Now I'm speaking not about pharmacists as if you're working in a healthcare system or a hospital, but commercial pharmacies, as well as pharmacies that support public clinics from getting the vaccine. There's nothing blocking us from doing that. But right now, our first tranche of vaccine, as we did with COVID and others, went out through the health departments. Now that we have a much bigger supply, I think you're going to start seeing that we're going to be able to move it more into the clinic, so that people who take care of folks with HIV, or people who are caring for populations enriched in men who have sex with men, so gay and lesbian clinics, STD clinics, these kinds of places, where we really want to get the vaccine so they can offer it to folks there. And that may be that we also find that there are pharmacies and pharmacy chains that work with the same network of people that we want to target for vaccine delivery, to ensure they have it on hand if someone comes in and needs it.
Okay, and then also along those lines, I know you brought up the distribution with regards to pharmacies. I know that a lot of this is very similar to, or kind of trying to tie it to, the COVID-19 situation. A lot of the pharmacies that initially received the distribution were the large or big chain pharmacies such as CVS and Walgreens, and a lot of the independent pharmacies had to go through more of a federal partner with, like, say, CPESN, the Community Pharmacy Enhanced Services Network. Do you expect for it to go that route again?
I don't know, but I think that it's a priority to get the drug into communities that may not. One of the things we want to do is get it to people who wouldn't otherwise have access. I hope I illustrated that we often see the people at the front of the line are the first to get something, but it's the people who are more to maybe in the middle or in the back that we really need to get, that we want to get everybody access to these things equitably. And so finding a way to bring it to those communities is going to be instrumental. And I know of places, living here in Atlanta for sure, community pharmacies are a instrumental institution for getting things into communities that need it. Now, whether there are pharmacies that cater right now to gay, bisexual, same gender loving, or other men who sex with men, that's hard to say. There are pharmacies that have a big footprint in the world of HIV drugs.
Right.
I think those are ones that would, and those would probably be some ones we'd want to think about first. And they also tend not to, there are some, of course, some of them, Walgreens, CVS have a big investment in that, but there also are some smaller chains of and independent pharmacies that have a big footprint there as well.
Right, independent pharmacies with some specialty pharmacy, yes.
Mhm.
So another question from Tori Wiley, may you share some of the commonalities and the clinical characteristics, if any, or possible causes found in the rare population, such as women and children?
Mhm. So we definitely are seeing women and children who have been diagnosed with monkeypox, thankfully well below 1% of the total so far. In the case of, so just a little bit about the epidemiology, and thus far, although we're examining each of these cases very carefully, of the women that have been interviewed by health departments and disease intervention specialists, thus far we've been able to pretty much establish some connection with a man who had monkeypox or someone else who had monkeypox. So the point I'm trying to make here is that sometimes within a network of people, you'll get communication or spillover into another network. We've been to this rodeo before. A lot of us may remember when HIV first appeared on the stage, everybody thought, oh, this is a disease of gay people. And in fact, it was spreading to lots of other people at the same time. We want to make sure we don't make that same mistake again twice. HIV has turned out to be predominantly heterosexually transmitted in the world, not here, but certainly sub-Saharan Africa and part of Asia. And we want to make sure that if their disease is spreading in other populations, we detect it quickly. That's why I was emphasizing the careful investigation they do of women, and the same with children. I just want to be also voice one note of caution here, which is I hope everyone appreciates that a child who's diagnosed with monkeypox doesn't mean a child who's been exposed to sexual abuse. People, sometimes people, because it started as a sexual disease, people think sex might be involved, but children could get it through all kinds of just normal interactions. Normal, I mean, sex is normal, but sex with children is not. But through just the regular routine interactions with someone else who has monkeypox. All it requires is close skin-to-skin contact. And it's that skin-to-skin contact that occurs during sexual contact. That's one very efficient mode of transmission, but there are others.
Right, great highlight, thank you. And also, there's a question regarding heterosexual transmission, which you just spoke about. Somebody wanted to know kind of the specific risks associated for heterosexuals.
Mm-hmm. Well, at this time, we don't have a way to numerically describe like how does the risk of vaginal intercourse versus anal intercourse compare. That's something that we know well for diseases that have been around for a long time, like HIV is a good example. But what we do know is all it takes is skin-to-skin contact. And I think that's what alarms me also, is that it could be transmitted heterosexually probably pretty efficiently. It just hasn't taken off yet. But that's why we're keeping a very close eye on cases in women, in particular cases in young people. Some folks have raised concerns that with college coming back, online, if you will, this fall, we often see a blush of STDs in co-eds. And are we going to see monkeypox? I hope not. I hope not. But it's a good reason to be communicating now with young people, frankly, about what the risks are and what you can do to ameliorate those and reduce them.
Okay, all the more important for education with regards to the
Yep.
disease. What factors are predisposing underrepresented populations to monkeypox? Why is it so high in those populations?
That's a complex question. We've asked this for years, right? Why are African American gay men, for instance, so much more disproportionately affected by HIV than white men or Asian men? And the lasting conclusion you walk away from this is that there has to be some underlying racism at work. This isn't just, there's structural inequities that are in place, and that plus institutional homophobia that really are driving people in pushing people into places where they can't necessarily reach out for help, they're not willing to reach out for help, they're not able to feel comfortable sharing. I mean, it's fascinating. In Europe, how just open-minded people are about sex and what happens. And, they're beginning to see, by the way, in many European countries, they're watching this disease now start to really plateau. So I think the same story that explains why we see these disproportionalities for HIV and STDs is what's going on here as well.
Mm-hmm. And speaking about that population, I know we learned a lot with COVID-19 again about populations' feelings about the vaccinations and vaccine hesitancy or awareness. And it was very difficult for some of those populations to actually decide whether they wanted the vaccination or not. So how do you think the numbers will look with monkeypox due to that additional stigma?
Yeah, that's correct. Right. No, that's a fabulous
Right.
question. And let me just add to what the stigma argument. When you get the intradermal vaccine, you put it in this part of your arm, in the forearm, right? So I could be walking around like with a red letter, like like
Scarlet letter.
a scarlet letter that I got the vaccine. And it's really interesting. We've been speaking to some men who are attending a big event in New Orleans right now. And some of the men are like, oh, my badge of honor, right? I got vaccinated. Other men are like, no way, Jose, am I going back to my home in Mississippi and people see this thing on my arm? Can you put it somewhere else? So I think that that's the first stigma that I worry about this time. The good news, though, is there is some good news here. When we looked at who got vaccinated for COVID, fascinating finding. But what population of people had the highest rates of infection? LGBTQIA plus people. Possibly a result of being marginalized for so long that and being sensitized to disease through HIV and STDs that may have, and the desire to get what you can has driven that. But I do think I would not be surprised if we see some racial and ethnic differences in how this plays out. Our job is to counter misinformation, to reassure people it works well. It has no side effects to it's hard for me to say what misinformation we have to discredit because I haven't heard the crazy things yet that we heard about COVID. But just remember, this is like any other vaccine. It's safe and it works and it is going to protect you.
Right. Okay, we have a couple more minutes to get a couple additional questions in. And as you know, we're reaching the end of August, approaching September, and some schools, of course, have already gone back, but there's others that start around next week. So a lot of them are having town halls to discuss monkeypox. Should parents be concerned about monkeypox as the school year begins? And if so, what can they do to prevent transmission, even though it will be difficult?
Yeah, well, the good news is if monkeypox were so easily to transmit that groups of people hanging out together without having close intimate contact like sexual contact could get it, it would have spread much faster and it spread out of those networks much faster. So I think what I would say is, look, we haven't got a signal that it is easily or rapidly spread in groups of children. We worry about congregate groups. I worry a lot about homeless people, incarcerated people, people who are in institutions of higher education, as well as the school setting, because these are places that bring people together. Nursing homes, I'm a little bit worried about. That's a big problem for COVID. Don't know. But what we're doing is two things. I think saying, on the one hand, reassured that we haven't seen it blow out in a group like this yet. On the other hand, cautious. We're watching closely. We want to know about these cases. They need to be reported to a health department so they can be investigated. But I still think even when identified early, we have the means to control it with just conservative means of separating people for a short period of time, at least separating those who've been exposed or known to be infected. So it's one of these sort of things it's easy to get panicked about something. And I just want to try and remind people, take a deep breath for a minute. Right now, we don't have evidence that this is happening, but we're watching closely to make sure that if it does, that we're there to take care of it.
Okay. Dr. Brooks, I have about 2 more questions in the chat, but I just also want to make sure that everyone is still aware that you can raise your hand or unmute so that you can ask a question as well if you would like to do so. I haven't seen anybody yet, so I just want to make sure everybody's aware. You did mention prisons. So there's a question from Leonard Edlow. Dr. Edlow, has the CDC seen any outbreaks in prisons?
I have to think for just a moment. I think we may have had a case in a prison, but we haven't seen an outbreak, to the best of my knowledge, in a prison. I mean, not like COVID-19, right? Where, just the whole prison overnight, everybody's got it. Nothing like that. If there has been, and I think there may have been in one jurisdiction here, it was a very limited, it might have been only one person, in fact, potentially acquired prior to entry into the incarceration system.
Okay. Well, that's good to know.
Same with homeless, though, by the way. We've also had cases in people who were homeless, but not
Mhm.
obviously spread within a homeless shelter.
Right. Okay. Let's see. Dr. Riley says there have been reports of patients complaining about the pain and post-site reactions of the intradermal injections. I know you had the slide talking about the data from previous. The injection pain for the intradermal compared to the sub-Q. Has that been considered in the goal to reach the target number, particularly if they don't return for the second dose?
It has. We're worried that could dissuade some people, but we consider that when making the FDA considered that we talked to them about it, but it was they made the ultimate decision. But together with us, we were happy to participate. We considered the discomfort and pain aspects of this. The folks who ran the clinical trial led by out of the University of St. Louis or St. Louis University, I can't recall which way it goes. I think it's SLU, St. Louis University. That they had, when they did these clinical trials, they accounted very carefully for this, and they actually did see increased redness, swelling, and a little bit of increased pain in people getting the intradermal dose. If somebody has that, a couple of things I can say. First, it's perfectly fine to administer the second dose in the other arm. I think that's what we recommend. And using non-topical, at least for the time being, non-topical drug can help. So some acetaminophen, some basic over-the-counter pain reliever. But we would avoid, at least for right now, any topical steroids or topical antihistamine products, just because we don't want to reduce the local reaction, which may be the vaccine taking. But you can take Benadryl or other pain medicine or anti-itch medicine to try and manage the redness and the swelling if it gets really intolerable. And I'll just lastly say some people will get a little, not many, but some people get a little nodule and can get some skin darkening, but all of that will clear, although in some cases it's taken a number of months.
Okay. And then last question before I turn it over to Dr. North to close out. Somebody did mention masks. I know that since the scare with monkeypox, people have kind of gone back to those that kind of dwindled down with using the mask have started back because of the fear with monkeypox, but because of the skin contact, really transmission, the masks really don't help that much. Is that what it is, boils down to?
Yeah, sort of. Yeah, I mean, the main risk of transmission is through skin-to-skin contact. I think that there isn't any evidence that if all of us were wearing masks, it would have the same impact on reducing monkeypox the way that it had for COVID, because it's really a discrete network of people in which this is transmitting right now. Now, if you're a man who has sex with men and you're sexually active, you might want to consider wearing a mask if you'd like. That'll make you feel better. And certainly it'll protect you against COVID. I'm a big proponent of that. What we do recommend a mask for is if you're a person who's been diagnosed with monkeypox and you're supposed to isolate at home or alone for 21 days, but people do have to go out and sometimes take care of things like go to the doctor. Sometimes people are living alone, they have to do some shopping. That's the time to wear a mask, because in a person known to be infectious, we want them to cover their face so that they're not exhaling virus.
Awesome. Well, thank you so much, Dr. Brooks. It's been a pleasure mediating the questions for you. I will send it over to Dr. North for the remainder of the session.
So thank you, Dr. Brooks, for spending your evening with us. And this is a partnership that we hope to continue to nurture with the CDC. And so I want to give an opportunity to thank you, but also the team behind the scenes. And so I want to put the spotlight on the many members of the CDC who are with us. If you like, you can turn your cameras on and you can be spotlighted and wave and get some shout outs, because if you look over my right shoulder, one of my presidential theme is Black by Popular Demand, and that's pharmacists and other pharmacy united leaders aiming to reach demand. And I think your presentation told us this evening why we need to demand the popularity of the issues that are affecting the Black community. And that's not an exclusive popularity. It's that if we see improvements in Black communities, then we would see there they are. So if you're part of the CDC team, be sure that you access your camera and get some of this NPhA family shine here. But if we do that in the Black communities, then we would see improvements in other community, and even in the intersections of those communities that you mentioned, like LGBTQIA and other avenues. So I want to thank you publicly and allow you all to be spotlighted here. I also want to take the opportunity to bring Dr. Unonu back onto the spotlight and thank her for doing such an amazing job here with us tonight. And so again, if there are presentations that you want to hear speaking to the general membership, please send us an email to npha@npha.net so we can provide these opportunities for you, because we want to do the hard work of making Black issues, but issues that are affecting our community in general, popular. So thank you for that. I also want to thank a behind the scenes person who you saw lots of things in the chat box, Dr. Angela Riley, for putting that contact in and really fortifying this relationship that you see here tonight. So again, I've shared lots of things at the beginning. Those will be coming out in our newsletter. If you're not getting our newsletter, please subscribe at npha.net or go to our website. And with that, I want to really thank you for being here, our members and our potential members, because we're putting this on for you and to provide opportunity for you. So thank you. And I want to say good night, but it might not be a good night for some people. They might be going out to dinner. So have a good evening. So as people are leaving, we can debrief when they